Good evening, welcome to the first ONcase night. Do you want to learn clinical treatment procedures from the expert, including their tricks and the decision making? And are you also interested in the biology and science behind? Without reading publications and books? Then you're right at the ONcase night. We will bring you an interesting case every time, and we will discuss it with experts, both from clinics and science. And now, let me welcome our first clinical expert of the ONcase night. He's a renowned sports medicine specialist, one of the best in Switzerland and abroad. And he's a pioneer in regeneration. He constantly tries to improve his techniques and shares with others. It's my big pleasure to welcome Professor Matthias Steinwachs. He's the director of the Sports Medicine Clinics here in Zurich, and also the current president of the ON Foundation.
Hi, Kai.
Thank you. Matthias.
Thank
Great
you
having
for
you
the
here.
invitation.
Have a seat.
Thank you.
Matthias, I just told the audience that we will discuss an interesting clinical case in this ONcase night. You've brought one. Which case would you like to share with us?
So I want to share a special case with, I would say, a delicate lesion combination, which is not very often. We see sometimes. It is a corresponding lesion, like kissing lesion in the patellofemoral joint of a 30-year-old physiotherapist. He get injury with a bicycle and a direct trauma, and he suffered for pain and limitation in load and many other things.
Can we have a look at a clinical exam?
Yes, of course. So normally we analyze the function of the joint, the range of motion, stability of the ligaments, and in this case, very important to look for the tracking of the kneecap, because many of these cases are related with some instability or other reason. Here we see ligament testing from the anterior and posterior cruciate ligament.
What are the possible injuries that could lead to these clinical symptoms?
Yeah, I would say it's classically the direct trauma in this case, because the corresponding lesions are mostly only as a fresh trauma related to a direct injury, an impact.
Okay, can you lead us through the next steps, which lead us to the complete diagnosis?
So I want to conclude. So he has effusion in the joint, which is a strong sign for some biomechanical problems. He is unable to give the load in the bending position of the knee, including sports, stairs, something like that. Next step would be to look for the MRI if there is something wrong. And we could analyze the surface of the cartilage. In this picture, you see the bone bruise on the medial patella facet with a grade 3 ICS cartilage defect corresponding in the more center part of the trochlea. We see the articulation damage in the trochlea center. So there are two lesions, like kissing lesion, in one side combined with subfrontal bone edema.
And I guess next step would be arthroscopy.
Yes, that we have done in this case to look for mechanical properties and look how the joint is completely inside. In this case, you see here in the center of the trochlea the defect on the trochlea and on the medial part of the patella facet. Some unstable cartilage fragments around. The rest of the joint looks completely healthy. So this is a medial compartment. You see the tibia cartilage is fine, and the meniscus is okay. And also the femur condyle is intact. So we analyze that carefully and look here for the ACL stability, PCL stability. There is no so much inflammation, a little bit you see here on the synovial tissue, but this is good. comparable to the history of patient and good comparable also to the limitation, because there is no other reason why this patient has so much effusion and limitation in their daily activity. Here a little bit, the lateral compartments also intact, so no chondromalacia or something else.
Thank you very much to take us through the diagnosis. Now let's start a decision making. What kind of channel treatment procedures would exist for such a kissing lesion?
In general, to treat cartilage lesion, we have many opportunities. So based on debridement, arthroscopical cleaning, we have microfracture like bone marrow stimulation techniques, bone marrow stimulation technique plus biomaterials, the classic MACT or ACT, so a cell transplantation technique, and the osteochondral transplantation technique, means OATS, which are in general available. And in this case, we have to address some biomechanical factors for the decision making.
And now, which was your decision? Which procedure did you choose?
So if we review that, so the debridement is not a successful treatment over time. It's reduced symptomatic but cannot restore the cartilage. The microfracture or bone marrow stimulation technique alone, this is not successful over time in a case where we have corresponding lesions in a size like this one. The lesion is more than 2 centimeters square. ACT or MACT is in this situation with a kissing lesion not recommended, and we will not get any reimbursement for that at that moment from the healthcare system. And the OATS are not successful in the treatment of patellofemoral joint diseases. It's normally not recommended at that location, just not in a corresponding situation.
So if I follow it correctly, that leaves you with AMIC.
Yes, in the end, this is the only one which is addressed in a size more than 2 centimeters square, just also robust enough to cover defects which are corresponding in this case. And it's a little bit delicate, but I think if you address the rehabilitation protocol and enhance the biological, there's a chance to treat patient with that lesion in the situation like this.
Okay, great. Before we come to the treatment and a rehab, I'm wondering about the access. Are you going for open access, arthroscopic, mini-open?
So in the approach to the patellofemoral joint needs an open access, that's for sure, because otherwise you would not be able to treat on a patella side and on a trochlea both. But in other locations like femocondyle, there would be a possibility for minimal invasive or sometimes also in an arthroscopic setting.
Okay, now we talked a lot about decision making. I'm sure that everyone wants to see the surgery now. Can you show us surgery and explain the key parts of it?
Yeah.
Maybe what's new and what's standard?
It's a pleasure. So in this case, you see the defect exposed on trochlea centralized. The first step is to clean the damage of cartilage and create stable cartilage walls. So it is not an osteoarthritic joint at that moment. It is an isolated, circumscribed cartilage defect, and this is important. Now we see with a thin scalpel, I cut the edges, and I use these pieces of cartilage for the minced cartilage process, so not the damaged one, so more or less healthy one. The next step is to clean the sclerotic bone part. If you have defects which are older, then you have more sclerotic situation. If it's more traumatically, you have less sclerotic. Now you see the key wire drilling, so this is one of that what I favorized because a better approach to the bone marrow. Here we see the corresponding defect on the kneecap. The procedure, it's quite similar. So we removed the unstable part and the damaged part of the cartilage. We be carefully with that. The next step would be that we, after drilling, we create a template to sizing the defect to cut the collagen membrane afterwards in the right shape and form. That will be used in a template. This is standardized, I would say. So if it's precise cutted, then it is easy to cut the membrane in the same shape and form and makes it easier. So I put the template on top on the outside area of the membrane because the membrane has one more rough side. This is related to the bone part of the defect, and the more closely part, which is more outside. I put the template on top and then I cut around. I cut with a dry membrane. It makes it much more easier for cutting, for right cutting. But we have to accept that the membrane are a little bit increase in size. So you have to calculate it 10% plus in sizing. Here we have collected before the PRP from patient side. Now we put some calcium too to activate the clotting function. It's like a fibrin PRP complex, which are built out in that. It's important because not all the PRPs are similar in the components and in their biological function. I drop the PRP on the dry membrane. It's like a drug delivery. So you see that this fibrin activated PRP is dropped on, and afterwards the small cutted minced cartilage pieces are put it on the membrane side and were stabilized with fibrin glue and PRP2. So it comes more in a solid construction, and it is easy to transfer in the defect under this condition. You see here a little bit more adding the PRPs, yes. And then you can put them with the normal instruments, and here is a special. What I do some needles in the drill holes and give a small portion of PRP on the subchondral bone. We can discuss later what is the sense of that. But I see that the activation of the stem cells starts in the bone marrow in that holes, and it's also something could avoid any hypertrophy of bone reaction. You see here some gluing on the defect, and then you can put the membrane on top with the rough side down to the bone. So the minced cartilage particles and everything, it's under the membrane. So you have like a biochemical box which is closed, and I close that with sutures around. And to the outside area, there is something like a barrier, and under the membrane, between the membrane and the bone, there is a bioactive chamber which allowed a load-free and safety rebuilding of the biology. The suture process is a little bit delicate because we use 6O suture material, so this has to be carefully, and it's you need carefully hands for that. The membrane is a little bit under the niveau, under the surrounding cartilage. So this gives an additional protection and an additional fibrin glue to cover the sutures. And here is the corresponding big lesion on the trochlea. Same procedure was done, drilling, PRP application, loading of the membrane with PRP and minced cartilage, and then we put it in the defect. So you see the bone marrow is working. You see the bleeding on it. And then you suture the flap back in this position also with suture material. This is a final view, so you see the fibrin glue on top and the restored trochlea defect in place.
Thank you very much for explaining your technique. It looks pretty sophisticated. Mm-hmm. What are the most critical points where people should put attention or where it needs special skills?
I think the cutting and preparation of the defect is a crucial point. So if there is a sclerotic bone, you have to remove that. You have to look for a good biomechanics on the surrounding cartilage walls. That's important. You have to cut really the cartilage which is completely damaged, to be carefully, because otherwise the cartilage goes wrong over the time, because the edges are important for the integration of the new builded cartilage, and we don't need any gaps for that.
Okay, and something else that looks critical, and you mentioned it's difficult, is the suturing. Would it be possible to glue instead?
I think the suturing is indeed more delicate, because this is more work for vessel surgery as orthopedics classically. But anyhow, I think biomechanically it's the best fixation what is available, and in a sizing of a defect more than 2 centimeters like here, or in a situation that you have a corresponding lesion, it's important that the stability of the flap is be stable over the time and allowed you to activate the patient very early. So it can be glue in smaller defects, yes, but in the bigger ones and delicate cases like this, I would not recommend that.
Thank you. Is there some tricks you can share regarding your perioperative regime? How are you doing this?
Yeah, I use normally hydraulic lifter, so I can bend the knee in the right position. This is important. I use a tourniquet at all. After the operation, I use the Redon drainage, but without the suction. That is also important, because I want not to remove everything, so only what create a high pressure or create more symptomatic for patient.
Thank you for sharing these tips as well.
Thank you.
Now, there's a lot of science and biology behind these regenerative procedures. And in the ONcase night, we also want to explain these important parts of science and biology. And for that purpose, we invite specialists as well. Tonight, we have 2 specialists joining us, one from the United States and one from Italy, to help us with these backgrounds. First, it's my big pleasure to invite a real pioneer in regeneration. He holds many patents in the field, and even one on the cartilage membranes like we have today. Professor Myron Spector joins us from Harvard, and he's the best person to talk to with questions regarding materials.
Yes,
good evening.
Good evening. It's a pleasure to be able to participate in this ONcase night program. And so I wonder, how can I help?
Myron, Matthias has shown us a wonderful case with cartilage defects, which he covers with membranes. Can you explain to us the idea behind this defect coverage?
Well, yes, of course. You know, when it comes to the idea of applying a covering membrane in a cartilage defect, we can be reminded that cartilage defects are open to the joint space, which is filled with synovial fluid. So if we want to contain any agents inside a cartilage defect, it's necessary to cover the defect. I mean, when we think of autologous chondrocyte implantation alone, one would never think about injecting the exogenous chondrocytes, the cells, the autologous cells, into a defect that was not covered. I mean, you'd imagine the cells would just disperse immediately in the joint space. And that solution to that was to apply a covering membrane in the form of autologous periosteum. To apply that membrane first, suture it, use some fibrin sealant to make it watertight, and then to inject the cells into that defect. Now, the same concept can be applied to procedures in which the cells are drawn from the subchondral bone, for example, in microfracture. Or alternatively, when cells are administered first to the covering membrane in the procedure MACI. So whether we're talking about ACI, AMIC, or MACI, a covering membrane plays a central role.
Thanks a lot for sharing with us the logic of the covering membrane. I assume that the material itself is not trivial. Is there special characteristics we need?
Yeah, so it's important to think about the properties that we desire to have in a covering membrane. Again, if we turn our attention back to autologous periosteum, in fact, that membranous autologous material worked well as a membrane. It could be sutured to the defect and with time underwent resorption. The problem, however, is that because the membrane contained living cells, there were incidences of hypertrophy from the membrane and also some changes that were found in some experimental models in the subchondral bone, increase in bone density. So we would like to keep some of the features, some of the properties of the autologous periosteum, but in a membrane that was acellular. And since the periosteum is fundamentally structurally made by collagen, it made sense to think about an off-the-shelf collagen membrane. The benefits are twofold of a collagen membrane. One is that the collagen provides cell adhesion ligands for the integrins of cells so that cells can adhere to the collagen membrane. That's of importance when it comes to the adherence of the membrane to the cartilage and also certainly for procedures like MACI when cells are added to the membrane. A second important property is that the collagen can undergo enzymatic degradation. So the cells that eventually populate the cartilage defect can release matrix metalloproteinases, enzymes that can break down the collagen, and therefore one can have a rather natural degradation of the collagen membrane after it's served its function. So those two benefits, I think, are exceedingly important and cannot really be met with most synthetic polymers if they were to be fashioned as membranes.
Thank you very much, Myron, for your explanations. Now we also understand why these materials work so well biologically. Thanks for being with us tonight, and best regards to Boston.
Well, it's been a pleasure to help out tonight. This is an interesting and important topic, and it's important toward treating many of our patient problems. Thank you.
Thank you. Now let's move on to the clinical evidence for this procedure, for AMIC and also the other biologic additions you did. And we've got the opportunity to talk to a second specialist tonight, and she's talking to us right from her lab in Italy. We will talk, and there she is, to Laura Di Girolamo. She is the director of the Orthopedic Biotechnology Lab, as well as the director of the Regain Institute in Milano. She's also the chair of the Orbit Orthobiologics Group of ESCA, and therefore she's a real expert in the field. Good evening, Laura.
Hello.
Good evening, Matthias. Good evening, Kay. And thank you very much for inviting me. It's a really pleasure for me to join this interesting ONcase. And it's also an honor to speak just after Myron Spector, who I had the pleasure to meet in Boston. And he's a great mentor for me. So I'm really excited about this. Thank you.
Thank you for being here to answer our questions. We've got many of those. The first one is...
I'm ready.
Yeah, we'd like to ask you for AMIC in comparison to other cartilage repair procedures. What can you share?
Yeah, we can classify the techniques for cartilage repairs that Professor Steinwachs mentioned among the surgical options he had for his patient into three main categories. Those that do not require cell or tissue transplantation, for example, debridement, microfracture, those that require cell or tissue transplantation, such as autograft, allograft, and finally, those more complex that rely on a tissue engineering approach, such as autologous chondrocyte transplantation. AMIC is a matrix-assisted microfracture techniques, and therefore we can say it belongs to the first techniques group. Let's say the most convenient because they are one step, not donor-side morbidity, but at the same time also among the cheapest. But nevertheless, as reported in literature, the combination of such membrane with microfracturing allowed to obtain results that are superior to microfractures alone and non-inferior to more complex techniques such as autologous chondrocyte transplantation or matrix-induced autologous chondrocyte transplantation. I can mention you a nice randomized controlled trial conducted on 47 patients who were affected by a chondral lesion of the knee. And this randomized controlled trial demonstrated the superiority of AMIC over microfractures at 5 years follow-up. The authors observed a progressive and significant score degradation in the microfractures, which at the beginning performed quite well, but then along the time frame of observation, they observed this degradation, whereas all the functional parameters remain stable for at least 5 years in the AMIC group. Similar results was also demonstrated by another study, but in this case, they were acetabular chondral lesions, so we're talking about hip. After 8 years from surgery, the patient who had been treated with the AMIC, actually, they show significantly better result than those that were treated with microfractures. And in particular, which is very interesting, I think, is that none of the AMIC patients required total hip arthroplasty in this time frame, whereas 22% of the patients of the microfractures group did. So that's a huge difference, I think. The same authors also show no difference at 5 years follow-up between AMIC and MACI, so the matrix-induced autologous chondrocyte implantation, again in acetabular chondral lesions. So I think the literature, we can say that the literature seems to prove that AMIC is really a smart technique to treat cartilage defects.
Thank you very much for your quick summary of that literature, Laura. We've got another tricky question from you, which is often asked, and it is whether drilling or microfracture is actually better to recruit the stem cells. Do we have an answer?
Oh, yeah, this is an interesting question too. Actually, drilling has been associated with osteocyte thermal necrosis, and therefore it was progressively replaced by microfractures that, however, they also have some drawbacks. For example, they are supposed to make the bone brittle, so fragile, and to lead to subchondral cyst formation. So based on this evidence, some surgeon has decided to return back to drilling due to a belief that drilling is less detrimental for subchondral bone and also may result in deeper penetration and give more access to the marrostroma. But let's see again what the literature says. A pretty recent systematic review on the basic science evidence included 7 basic science studies, so not so many, but we have to analyze what we have. But all these studies were quite homogeneous because they all compared the effect of microfractures versus drilling, evaluating mostly the subchondral bone, the effect of these techniques on subchondral bone, on bone marrow stimulation and cartilage regeneration. Among these 7 studies, only 2 are in humans, so we cannot drive definitive conclusion, but still it's important, the findings of this study. The authors actually were able to show that the deep drilling of cartilage defects in the knee resulted in improved biological features compared to microfractures, including less damage to the subchondral bone, and also greater access to marrostroma, and so also greater access to bone marrow cells. Although in general, the overall quality of cartilage regeneration was considered quite poor. So given this limited number of studies that are available, we cannot conclude that drilling is superior to microfractures. We need more studies. However, I also think that surgeon skills and experience can make a big difference. For example, in the word microfractures, I think we should put the emphasis on micro rather than fracture. So that's to say that the surgeon should be gentle, performing gentle microfractures that would prevent damage of the subchondral bone. And if I may, Kay, in any case, if the cell recruited from bone marrow stimulation are not enough, we can always combine AMIC, for example, with orthobiologics such as PRP, bone marrow aspirate, adipose-derived products. So this would give more chance, more cells to regenerate the defect. One of the most efficient ways is to soak the membrane in these orthobiologics, as Professor Steinwachs showed in his case. But of course, PRP can also be inserted beneath the membrane just before gluing or before suturing.
Yeah. Good news, Matthias. Evidence really supports what you are doing. And Laura also gave me a right question to you. You actually used AMIC and you supported it with additional steps like MITS cartilage and PRP. What are your thoughts behind that?
This is a little bit a philosophy, as I do marrow stimulation techniques approximately 20 years. And I see that also experimental as clinically, we have a low oxygenation concentration in the knee. So the cell migration and mitotic activity are in general less active as compared to experimental setting, for example. In this field, my feeling is that we need the penetration of the subchondral bone to enhance the nutrition quality in the repair zone. It's one of the ideas. The second one is the migration of the progenitor cells or stem cells. That is medicinal signaling cells. So these cells are not building up the tissue itself. That we can see experimentally, yes, but I think in human we are coming out to a more insufficient regeneration tissue quality. That's why I would say we need the stem cells for transport of the signal to specific differentiated cells. And these differentiated cells I added in the type of MINS cartilage, where the cells, the specific chondrocyte cells, are able to migrate and get the stimulation from the MSCs to repair itself and have access to nutrition and high oxygenation. And I see in some pictures in a follow-up of my treatments where we used injectable contrast medication during MRI, that the repair tissue is full of uptake of these contrast medication, which is only possible if they have access to the blood vessels. So I think we need this nutrition effect in combination of the different molecules, because the joint itself is not really good able to restore itself, that we know.
This sounds very promising. Mm-hmm. Now let us discuss step by step the additions you're doing. Yes. Let's start with the PRP. Laura, what's the actual function of PRP, the mechanisms of action?
Yeah, so first of all, I would start saying that PRP stands for platelet-rich plasma. Therefore, it's considered a platelet-derived product. It contains both platelet and also plasma proteins, most of which are growth factors, such as PDGF, TGF-beta, FGF, IGF, and others. As you can see in the picture, accordingly to the target cells, these bioactive molecules can exert different response. For example, considering joints, PRP exerts an anticatabolic effect on chondrocytes by reducing degradation markers, whereas on synoviocyte, it increases hyaluronic acid production. And on bone cells, PRP induces osteoblast proliferation and collagen deposition. At the same time, PRP contains anti-inflammatory molecules, such as IL-1RA, for example, which is the receptor antagonist for interleukin-1, which is known to be one of the most powerful inflammatory mediator, and IL-6, And all these molecules can also, therefore, participate to restore the joint homeostasis exactly the way Professor Steinwachs said. So they are signals. In this case, they come from the PRP, they come from the blood. In the case of using MSCs, for example, they come from the cells. So the main effect of PRP seems to be related to the control of inflammation and therefore pain perception. Although we know that at the extracellular matrix level, PRP is also able to induce the increase of matrix and intermatrix ligands, eventually leading to a matrix which is more resistant to degradation process. So something which is objective. And these findings indeed have been corroborated by a recent systematic review of Professor Filardo's group that we conducted within the ESCA-Orbit initiative. The aim of this systematic review was to determine if PRP injection can induce a so-called disease-modifying effect, so something which is objective and not only pain perception of the patient or functional and clinical results. The review included 44 studies for a total of more than 100 animals treated of different size. And the main findings of the review is that intra-articular PRP injection actually showed disease-modifying effect in most studies, both at the cartilage and at the synovial level. So these findings are really promising, of course, although this should be somehow translated into humans, and we hope to keep going with our studies to demonstrate this as well in our patients.
Thank you. This is very promising, those data on PRP.
Yeah, it is.
Now, a question we hear many times, do all the PRP preparations work the same?
Well, actually, PRP is a broad term that we use to indicate many different products. So yes, they differ very much each other. They mainly difference in platelet concentration, leukocyte concentration, and usually higher number of platelets are associated to a more powerful product, as it would contain more growth factors and bioactive molecules, whereas a high concentration of leukocytes might increase, at least initially, inflammation, which we not always want. However, as usual, this is not as simple as it looks, because for some indication, for example, muscle lesion, we do want to boost inflammation, at least at the beginning. So that this to say that there's no the best PRP for everything. It depends on its use. And in this regards, the new tendency is to design specific PRP preparation for given indication. For example, some PRPs are only indicated for joints because they contain growth factors which are more specific to the joint environment. We should also remind that PRP can also differ in terms of blood volume that we need to harvest, number of interval, of application, interval of administration, and yes, of course, also in terms of cost to produce it. So at the end, I think that all of these things should be taken into account before treating each of our patients, and that chosen according to the indication.
Thank you for that explanation. Now let's come back to the specific application of PRP as an augmentation to AMIC. Do we have clinical evidence at the moment?
Well, we don't have a strong clinical evidence, but we have some nice papers in literature that report the combination of AMIC and PRP. As we said, AMIC is a versatile technique, as it can be augmented by combining the metrics with different orthobiologics, and PRP indeed is one of them. Some studies report a modified AMICs where microfractures were complemented or in some cases replaced by the use of mesenchymal stem cells or PRP. But yes, I think that despite these very promising findings, there's no evidence about PRP plus AMIC in literature yet, or at least is not a strong one. We have evidence of its efficacy, but we cannot conclude that it's more effective than AMIC alone. In our group, we conducted a randomized control trial. Professor Volpi was the leading surgeon, where we compared traditional AMIC with BMAC, so bone marrow aspirate concentrate, And what we observed is that at the last follow-up, which was around 9 years, we did not observe any difference between the two groups. But what is important is that at 1 year follow-up, the AMIC plus BMAC patients perform significantly better than the AMIC alone. So this means that augmentation can be very useful in the first phases of the regeneration, and therefore very useful in those patients where recovery times matters more than for other patients, for example, athletes. However, as I said, more studies are needed, especially to get to conclusions that are more definitive.
Yeah. Thank you. Now let's move to the other biologic factors Matthias used in his treatment, the minced cartilage and the fibrin. How would you, Laura, explain the mode of action?
So the principle of mincing cartilage is to create a larger surface area for cartilage expansion. We can imagine minced cartilage repair like something not very far from the theory of autologous chondrocyte transplantation. But in this case, we not only provide cells alone in a suspension, but we provide autologous chondrocyte within their native surrounding matrix. So we can say we are providing cells with already together with the natural scaffold. And therefore, this incorporates the key factors for a successful tissue repair or regeneration. Fibrin is used to mixed together with the minced cartilage during the surgical implantation, and therefore it serves as a glue, like an adhesive. We know very well from old studies the positive effect of fibrin on chondrocytes. Many scaffolds indeed are composed by fibrin, but in this case, in my opinion, I think that the scaffold is made by the cartilage ACM, so extracellular matrix itself, and therefore the role of fibrin is mainly mechanical in this case rather than biological. Of course, we cannot exclude there's also a biological effect, but I think that if compared to other techniques where fibrin is used together with the cells which are in suspension, in this case where cells are already embedded in a matrix, which is a native one, the biological role of fibrin is lower.
Now, how about the PRP? What's the effect of the PRP on the minced cartilage?
So likewise, AMIC, minced cartilage technique can be augmented with orthobiologics, as Professor Steinwachs said, to further improve the outcome. I just mentioned that PRP has an anabolic effect on chondrocyte as well as a chemotactic action. That means that PRP can somehow convince chondrocytes embedded into the cartilage extracellular matrix to leave the tissue and start colonize the defect, because in this case we need to fill the gap, fill the lesion we had. So the influence of PRP when associated with minced cartilage could be very relevant.
Thank you. That confirms what your hypothesis. Now, Laura said that with the fibrin you create a scaffold itself. Does it need a membrane?
Of course, similarly to what happens in AMIC technique, where the marrow clot coming from microfractures or drilling is protected by the matrix, the use of matrix with minced cartilage can serve for the same function. So that is to stabilize the volume of the cartilage repair. However, while in the AMIC technique, the matrix is fundamental because it creates the regeneration chamber, as Professor Steinwachs and Myron Spector explained very well. In my opinion, with minced cartilage, it's less strictly necessary, although of course it can contribute to a further stabilization of the implant. I'm aware that surgeons mainly use the combination of minced cartilage and a matrix for patellar and trochlear defects because of their localization, whereas usually for femoral condyle defects, the isolated fibrin glue fixation is applied.
Thank you very much. Now, let me come to my last question. For that specific procedure that we've seen tonight, is there already clinical evidence or evidence in literature?
You mean the combination of...
The AMIC plus, the combination of everything.
Yeah, I think it's the combination of EMIC with other orthobiologics or like PRP or bone marrow is not a strong evidence, as I said, but EMIC alone actually has a strong evidence in literature. So there's a recent systematic review recently published by Professor Steinwachs and other co-authors, which included 12 studies for a total of almost 400 patients that were treated with EMIC for knee chondral lesion with a minimum follow-up of 1 year. And the result clearly showed that the patients who had significantly improvement of pain from baseline to follow-up, as well as also improvement in the main international scores for functional activities like LISOM or IKDC. And those results were stable up to 3 years. And I think what is very important in this systematic review is that this evidence was obtained not in a selected population, which is typical of a randomized controlled trial, for example, but it was obtained in a real-life treatment of chondral and osteochondral defects. And therefore, we can say that this evidence is sufficient to recommend EMIC in this indication. Then any other addition like orthobiologics, of course, could improve the results. But at the moment, I would say that the strong evidence is for EMIC itself.
Yeah. Thank you very much. Well, actually, as said before, it's a very sophisticated technique. It would be surprising to find a big literature base on that technique. It's new.
It's completely new.
It's new.
It is not proven yet. And it is, I would say, more a biological, theoretical background, which is proven in some preclinical studies, but it is not really a proven technique. But I would say there is a tendency for a new direction to enhance the biological elements, because we see on the bone marrow regeneration process a strong limitation for the long-run stability. So we have a strong need for a biological enhancement for that technique, because in the future, related also to cost relation in the healthcare system, we have a lot of problems to get reimbursement for treatment like two-step techniques or some other ones. So it has to be cheap and easy and effective, and that we are looking for.
Right. And what Laura explained to us is that it biologically makes a lot of sense. Everything fits together. So we are looking forward how that technique develops.
Yeah.
And with that, Laura, we thank you very much for your input, answering our questions.
Thank you.
And wish you
Again,
wonderful.
it was a pleasure for me.
Have a wonderful evening in the lab, but don't work too long.
No, I will not. Thank you.
Bye-bye.
Bye-bye.
Good evening, everyone. Bye-bye.
And now let's come to the probably most important question. Does that procedure help the patient? And we are happy we have the patient here tonight. Welcome, Massimiliano Mingolini.
Good evening, everybody.
Hi, Massimiliano.
Hi,
Great having you here.
Good evening.
Please.
Have a seat. Massimiliano, we just saw that surgery. It was quite a defect. Yeah. What did you think? What did you feel after that accident?
After the accident, I feel that I couldn't play sport anymore. I feel like I have a knee that is not doesn't support my normal sport activity. So I feel like someone who can do whatever he wants.
I can imagine that it's hard. And fortunately, you found somebody who does the surgery. But how did you see Dr. Steinwachs?
I've seen Dr. Steinwachs. He was suggested me by a doctor of Ars Medica in Lugano, and he suggested me to go to Zurich because Dr. Steinwachs, he said that he was one of the best, the most important surgeon of cartilage problem, and so I did.
Right, and I think we saw his skills in the surgery.
Yeah, exactly.
And we understood the biology behind. Mm-hmm. But we also know that's only half of the success. The good surgery, the good biology. The other half is the post-operative rehab.
Yeah, that's absolutely an important part. So I mostly pointed out that we have limitation in our own surgical part, so we have 50%, and the rest will be compliance of patient, the rest adaptation of physiotherapists, and many other things, biology in the background. And for that reason, we have to standardize the post-operative rehabilitation best as possible.
How do you do it?
For the rehabilitation after a cartilage lesion, so we have something about 3 phases. So one is the so-called protection phase, where there is no tissue in place after the treatment. There's only cells and biomolecules, so you have to avoid mechanical overload. For that reason, we have limitation in the loading of the joint for approximately 6 to 8 weeks. We have an adaptation of range of motion, so we have a limited increase of range of motion, especially on cases in the patellofemoral joint. So we start with maximal bending on 30 degrees, 2 weeks later on 60 degrees, 2 weeks later on 90 degrees, something like that. And we use in a 2 hours practice daily a CPM machine, which allowed us to increase a little bit the range of motion during the unloaded situation compared to the loading situation. So these are the elements. After these 6 weeks of protection phase, they come in an intermediate phase where the patient goes out of crutches and starting with loading carefully, pain adapted, swelling adapted. And after that time, the muscle and the sensomotoric function are stimulated and come stepwise back. So we have a protection for sport approximately up to 6 months minimally. In an impact sport, we would protect it longer.
Okay. Massimiliano, you're a physiotherapist and an expert on rehab yourself.
Yeah.
Maybe while we have a look at the video that you've taken yourself, can you explain your experience during your rehab?
Of course, in this case, as you see, I'm the second part of the rehabilitation program. I started putting much more weight on the knee and working a lot with proprioception exercises for making an equilibrium system to the knee. And in this case, we work with a machine that use mechanical system to proportionate the charge to the knee. That is not put in by the therapist, but is the patient that use his strength to put up the machine. Is not imposed by the therapist, but is the machine that do everything. It is quite good in this phase of rehabilitation. In the second phase, as I said to the doctor, there is the re-athletization phase. So I make some exercises that help me to improve my muscular strength, to be able to make exercises, to make jump, to have consecutive movement as used in a bike movement, and to put effort to make strength on my knee. Because the problem is to use the knee, because we have 2 knees. Balancing the efforts is not easy for a patient because it's not the conception using the knee in the same way. You have always a preferred knee. In this case, you have to focalize your work to your operated knee, to equilibrate.
And is that what you think is most challenging during that phase?
During this phase, the challenge in my mind was to do the same things I did before the accident, to make the same sports, to use the knee as it wasn't happened anything.
Now I'm wondering whether you are doing this. How are you feeling today?
Today, I feel like I have a new knee. I feel like there were no accident. I can jump, I can run, I can ride my bicycle easily. I am grateful to Dr. Steinwachs for his work.
Yeah, great. And even play basketball. As we saw. That's wonderful. Congratulations to both of you. Congratulations to a successful surgery. Congratulations to great work on the rehab and to being back in life.
Thank you.
And with that, we are at the end of the ONcase night. We hope you've enjoyed that first edition, and we would be more than happy if you can take some of the knowledge for your own patients. If you've got an interesting and well-documented case yourself that you would like to share, please contact the ON Foundation. Now, thank you for watching. See you for the next ONcase night.